So, tēnā koutou katoa, Kate Mila Falcha, bienvenue à tous, welcome. My name is Professor Sinead Donnelly, a palliative medicine physician, host of this fourth Drs-say-no international webinar. We are an international network with 500 signatories from 19 countries to an open letter advocating that euthanasia and assisted suicide are not part of medicine. We write that doctors should be left to focus on advocating for patients, to cure sometimes, to relieve often, and to comfort always. Please encourage your medical colleagues to consider signing this letter. We are privileged to welcome Dr. Frank Brennan, who's a palliative medicine physician based in Sydney, Australia. He's also a lawyer, and Frank has written on the human rights dimensions of pain management and palliative care. Frank lives in New South Wales, the last of the 6 Australian states to legalise voluntary assisted dying. Frank will present Euthanasia and Physician-Assisted Suicide, the Australian experience. Just to give you some technical details, the chat function is disabled, so please write your questions on the Q&A tab. Dr. Catherine Ferrier from Canada and Dr. Jan Kleinsman, Aotearoa, New Zealand, are on hand to attend to your questions at the end of Dr. Brennan's presentation. So I will now hand over to Dr. Frank Brennan to present. Thank you, Frank.
Thank you, Sinead. Just make sure that I can be heard. Good, perfect. No, thank you so much, Sinead, for that introduction and also for the invitation. I very much appreciate that from the Drs-say-no group and your facilitation, your personal facilitation of this talk. So yes, my brief here is to speak about this topic from the Australian perspective, but of course, Australia is part of a global story, as you know. Okay, so I'll start with an illustration or a picture of our country, the map of this extraordinary continent, this continent of Australia, as you can see, with 6 states, 5 mainland and 1 is in Tasmania, the island state at the base. We also have 2 territories, Northern Territory and the Australian Capital Territory, but it's the 6 states that have all passed voluntary assisted dying laws. The other aspect of this map, of course, is how vast this country is, and that does come into the story as the discussion unfolds. Australia has been blessed by many great poets, and one of them was A.D. Hope, and many years ago he wrote a poem called Australia. They call her a young country, but they lie. She is the last of lands, the emptiest. Each of the 6 Australian states have passed VAD laws. But VAD is an umbrella term that permits in certain circumstances both euthanasia and physician-assisted suicide. For the convenience of the audience, I'll be referring to these concepts or these acts as VAD or voluntary assisted dying. Prior to looking at the details of the laws, the most important advice we give to Australian health professionals is to read your own law. The law in each jurisdiction is subtly different. Too often doctors or hospital administrators say that the law says A or B, when A or B applies to other jurisdictions, not their own. So I think that that's an important aspect to start with the law of your own jurisdiction. All the laws have an identical structure. The description of the initiation of the VAD request, eligibility of the patient and the VAD doctors, conscientious objection section, the process leading to VAD, and the oversight and review section, the creation of a VAD board. Initiation. New South Wales, Queensland, WA and Tasmania, the health professional can initiate a VAD discussion. They can do that, but only if in the same conversation, the doctor gives information on other available treatments and palliative care and the likely outcomes of those treatments. So it must be in that conversation. Victoria and South Australia are stricter. A health professional cannot, under any circumstance, initiate a discussion about VAD. It must come from the patient. The VAD request. So I guess this has caused a little bit of ambiguity around the country in terms of what constitutes a true VAD request. All jurisdictions state to be a true VAD request, the request must be clear and unambiguous. That's the phrasing. Throughout the country, health professionals have realised they need to be careful in interpreting precisely what the patient is saying. Essentially, a patient may communicate one of three distinct thoughts. First of all, a desire to die statement such as, "I wish I could die, I wish this could be over." The second is a request for information on VAD. What is VAD? Or do you provide VAD? And finally, the true request. I want VAD, I want euthanasia. It is only the third that constitutes a true VAD request. The following are not true VAD requests. Statements like, "I wish I could die, I can't keep going on, I'm ready to die, this is all too much." It should not be automatically assumed, therefore, that these statements are VAD requests. Those statements should be responded to as we would normally do, with empathy, careful listening, and an inquiry as to what troubles the person. According to the response, we could explain what can be done to alleviate these concerns within the standard of care of palliative care. So I say to everyone, including the junior doctors, that a statement of a desire to die is, as it has always been, an invitation for us to sit and talk with this patient about what they are feeling. It's not a point of jumping up and running down the corridor to get forms. No, this was never a true VAD request. This was a desire to die statement. So an example happened recently, in fact, very soon after it became implemented in New South Wales. 71-year-old woman, metastatic malignancy, severe cancer pain. She was admitted to a faith-based hospice. As she arrived in clear distress, she asked, "Do you do euthanasia here?" Now, initially that was thought to be a true VAD request, and a whole series of things unfolded. But in fact, that was a question seeking information and not a valid request. What happened was very quickly there was excellent and rapid pain relief achieved, and there was no further mention of VAD from this patient. Also, other questions that have been asked, and now I can answer them in terms of Australia. A VAD request is contained in an advanced care directive or plan. No, a request for a VAD in advanced care directives or plan is not recognised in the law. VAD request comes from family or carers. No, the law does not allow for a person other than the person themselves to request VAD. VAD requests from family or carers on behalf of the patient, but Dad always said he'd want VAD in this situation. No, the law does not allow for a person other than the person themselves to request VAD. So to start the process, it needs to be a true VAD request from the person themselves. Eligibility of patient. There are mostly standard, these eligibility criteria are mostly standard across all Australian states, although there are subtle differences. In essence, all jurisdictions require the person, in order to be eligible for VAD, they must be an adult, an Australian citizen. There are some residency requirements in some of the states. The disease. The person must be suffering from one disease, illness, or medical condition, variously phrased as advanced, progressive, incurable. All laws state the disease cannot be purely a mental illness or a disability. So the person is not eligible purely because of a disability or dementia or a mental health impairment. Given the prevalence of cognitive impairment in residential aged care facilities, it is important to pause here and emphasise the following: that dementia alone is not an eligible illness for VAD. That if the patient has both dementia and another life-limiting illness, it would all depend on whether the person was competent throughout the entire VAD process, and I'll come to that. That's another important criteria. What about the level of suffering? So this is a subjective test. All jurisdictions give a subjective test of the level of suffering experienced by the patient. They actually use identical language. The disease is causing suffering that cannot be relieved in a manner that the person considers tolerable. They must be acting voluntarily. For a valid VAD request, the person must act voluntarily, that is, without coercion, duress, or pressure. If the VAD doctors are uncertain that the person is acting voluntarily, the laws require the VAD doctors to refer on to another doctor with the relevant skills to make this assessment. Capacity. For a legally valid VAD, the person must have capacity throughout the entire process from requesting VAD to the act of VAD. So I've had situations where the person did have capacity right up until the day where it was clear of the VAD being given, where it was clear the person had lost capacity and the VAD did not proceed. So in some of the laws, they actually go through what is a common law definition of capacity: understanding, retaining, reasoning, and communicating. There is a presumption in all the laws that a person entering the VAD process has capacity. Nevertheless, the law does place an obligation on those doctors to assess whether there's capacity. And if they're uncertain, the law does require the VAD doctors to refer on to someone with that skill to make that assessment. But a formal review by a psychiatrist is not mandatory in the VAD process. What about prognosis? The person has a limited prognosis. There's a spectrum across the jurisdictions. 5 of the 6 states say generally 6 months or less prognosis, and 12 months or less for a neurodegenerative disease such as motor neuron disease, otherwise known as ALS. In Queensland, it's 12 months for all diseases. What about the eligibility to become a VAD doctor? Well, all laws require 2 doctors to be involved in the assessing. Across the laws, there are varying levels of post-registration experience, and all laws require that these doctors have completed training. So you cannot be a VAD doctor if you have not completed the mandatory training. In Victoria, they talk about relevant expertise. One of the 2 assessing doctors has relevant expertise and experience. This has been interpreted as a specialist consultant in that area of internal medicine. Tasmania, the word expertise is absent, so arguably both doctors could be generalists, non-specialists, who have relevant expertise in managing this disease. Role of the usual treating doctors. There's a general sense in the laws that the usual treating team, whether or not they are conscientious objectors, continue to have a duty to alleviate the suffering of the person who is embarked on the process of VAD. The most explicit statement is in New South Wales, where the law expressly states, that it is unlawful for the treating practitioner to withdraw services that they would normally provide simply because of the VAD request. Therefore, for example, a physician who is a conscientious objector cannot withdraw their services to a patient or patient's family because of a VAD request. What about the administration of the lethal medicines? Well, they can be administered in 2 ways: self-administration or practitioner administration. Self-administration. This is the same as physician-assisted suicide. The VAD doctor writes a prescription, and it can only be a VAD doctor who can do that prescription of the lethal medicines. Once it's dispensed, it's in the hands of the person to ingest these medicines when they choose. What about practitioner administration? So here I'm going to return to the map, because you've got a situation, such a vast country as this, that you're going to have many, many areas in rural and remote areas where there's very few doctors around. So the legislators needed to work out how to do this, particularly in the large states such as Western Australia, Queensland, etc. So here, the health professional in a practitioner administration, the health professional administers the medicines directly to the patient. Usually this is done intravenously. In all laws, a VAD doctor can administer these medicines, but in those large states, the person administering the medicines can also be a nurse practitioner. In Western Australia, which is huge, that state, the nurse practitioner must have practiced as an MP for at least 2 years. Now, Queensland goes further and also allows a nurse who has practiced for at least 5 years, not a nurse practitioner, not simply nurse practitioners, but also nurses generally, as long as they've practiced for 5 years. All the above health professionals must have completed the mandatory VAD training. Conscientious objection. All Australian laws expressly state that a doctor must be a conscientious objector to participating in the VAD, may be a conscientious objector to participating in the VAD process. So it does give a legal protection for a doctor to become a conscientious objector. How far does conscientious objection extend? Well, I would say it's probably 3 possible areas here. One is participation, the core of the assessment and the administration or giving a script for lethal medicines. That's direct participation. Then what about giving information? And then finally, what about referring to another doctor, a VAD doctor? So in terms of participation, the conscientious objector clause say that does allow a doctor to have a conscientious objection, extends to participating in all aspects of the VAD process. So it gives a very tight protection for doctors. What about giving information to the person on VAD? So for New South Wales, the last of the states, they said that there was no obligation on a conscientious objector to give information. In the other states, as you can see, there are varying levels of information for the doctor, the conscientious objecting doctor, to give over, etc. I won't go into detail, but you can actually see that there's more information to be given in those other states. What about referring on to a VAD doctor? Well, in the Australian laws, there is no legal obligation on a physician to refer the patient to a VAD doctor. So in summary, an absolute protection for conscientious objectors from participating in all aspects of the VAD process. Information is a state-by-state story, and there's no mandatory requirement in the law for a conscientious objector to refer on to a VAD doctor. What about faith-based hospitals and hospices? And this goes back to the history of healthcare in this country, where certainly the Irish influence was very, very strong in the creation of so many hospitals around the country. And then so there's a strong legacy here of faith-based hospitals and hospices. In essence, all faith-based institutions must comply with the local VAD Act. Obviously, we're part of a polity, and we need to obey the law. In New South Wales, and I'm just going to concentrate on New South Wales because this is the jurisdiction I'm in, but the Act does provide that hospitals and other entities can decide that they will not provide VAD services. So can declare that they are non-participating entities, as it's called. So such institutions can also have a rule that no employee can participate in VAD on site or be present when VAD is delivered. Nevertheless, in accordance with the Act, such institutions must do the following. First of all, they must make transparent their policy of non-participation. This policy must be published in a way that is likely that persons who receive healthcare at that hospital will become aware of this information. Access to information. The institution must allow access to a VAD navigator service to enter and provide information on VAD to the person requesting that information. Response to a direct request, well, we follow the law implicitly from that direct request onwards, but as part of that, we explain that this particular institution does not participate. Then we've got a little bit of a knotty story here in terms of transfer out for other aspects of the VAD process. So if a person is in a faith-based institution, they're requesting for VAD, that's of course what we follow the law, but also we start to organise them to be transferred out to start to proceed with the VAD process. But the law also says that they acknowledges there may be a situation when that transfer is not appropriate, when the transfer might cause serious harm, adversely affect the person's access. So there's multiple things, but it's really the serious harm story that's the medical decision-making of that institution, whether this is not appropriate to be transferring this person out. And so those other aspects do come into play. But if any of those five do apply, then we simply say, look, we feel that this particular institution that we cannot transfer out. But what then? And the law is silent at that point. The law doesn't guide us from that point as to what to do from that point onwards, because the person may say, okay, you're not transferring me out, but I still want to proceed with the VAD. And we've already got a ruling that we're not allowing VAD doctors on site. So that's a conundrum that remains there. Death certificate. Each law has its own variation of what a doctor can or cannot write on a death certificate. Most ask the doctors to write in the cause of death the underlying disease and not VAD. For example, in the Victorian law, the cause of death would be, for instance, metastatic pancreatic cancer, and the manner of death would be the VAD. So it's really interesting, the teasing apart of cause and manner in there. The commonly asked questions: is palliative care referred to in the VAD Acts? Well, yes, it is. And all the Acts require the VAD doctors to explicitly inform the person of palliative care and the likely outcomes of care and treatment. The difficulty here is the level of understanding of palliative care by VAD doctors. Most Australian doctors have not trained in palliative care or completed a palliative care term as a junior doctor. So VAD doctors can come from multiple different backgrounds, of course, and the concern is how much they understand about palliative care when they're making those descriptions. As part of the VAD process, is it mandatory to refer to palliative care? No, none of the laws require the VAD doctors to refer to a palliative care health professional. Should VAD be seen as part of palliative care? Now, this is an interesting question. This is a universal question, not just for Australia. With the sole exception of South Australia, the laws are silent on this issue, but South Australia is very interesting because the law expressly states that VAD is entirely separate to palliative care. VAD is not palliative care, says the law. The administration of a voluntary assisted dying substance will be taken not to constitute palliative care of the person. So there's an example where a law around the world has stated, no, they are completely separate. Does VAD constitute suicide? Now, this is an interesting question because this was raised because concurrent with the state-based laws, under Commonwealth law, it is illegal to promote or facilitate suicide over a carriage service, over telephone, internet. So you cannot, the Commonwealth law says no. Many of the VAD Acts tried to move around this by stating expressly in their legislation that VAD did not constitute suicide. From that, it was argued that VAD doctors could legitimately make assessment by telephone or electronically. However, very recently, 2023, a federal court judgment stated the term suicide as used in the Commonwealth Criminal Code does apply to the ending of a person's life in accordance with and by means authorised by the Voluntary Assisted Dying Act. So it actually states that VAD and the suicide in VAD is part of the same story, and it basically reinforced the embargo on doctors using electronic carriage services to do that. So our patients cannot have these conversations with assessment, etc., by telephone or electronically in any way. It needs to be face-to-face. General comments. What will be the effect of VAD in Australia? Well, look, I think, obviously this is a broad topic, but I'm just going to speak about the Australian society, the institutions, individual healthcare professionals. That absolutely impacts there as well. So as members of society, look, I think in Australia, just like around the world, once any law is passed, it changes society. It changes the tone of that society. Laws prohibit or limit or open up a possibility that did not previously exist. The enactment of VAD legislation opens up a possibility that in certain circumstances, a doctor can legally prescribe, or a doctor or nurse practitioner, or indeed in Western Australia, a nurse can administer lethal medicines to a person. Through that law, the Parliament, and through it, the whole of that society enters a domain it has not previously ventured. It enters into a complex area and attempts to permit and limit actions that involve people with life-limiting illnesses and medical practitioners discerning issues such as capacity, vulnerability to undue influence, prognosis of serious illnesses, and the use of lethal medications. Challenges in prognostication. The reality is that determining the prognosis of a patient is notoriously difficult. So this is international literature, the precision, how imprecise imprecise doctors can be with prognostication. And I'm not going to go into this because this is more a general commentary about that imprecision, and most clinicians are not taught how to do it well, and even the best, most experienced doctors can get this wrong. Capacity. Well, all the laws, all the acts in Australia do say, yes, there is a presumption about capacity, but I guess we just need to be careful here. What are the elements of capacity? So some of the laws talk about that, and where the disease itself might, or its treatment may disturb capacity. So we know as clinicians that multiple things could potentially disturb capacity. And I guess we worry, of course, is whether that's on the mind of the VA doctors in a very true sense when they're sitting with patients and going through capacity. And the law does provide some relevant examples. These are laws outside of Australia, but laws that talk about pain, fear and fatigue could be so severe that they could disturb the ability of a patient to reason. In the VAD Acts, if a participating doctor is uncertain about capacity, they must refer, as I said. But it's in their judgment whether they do refer or not. And as I said, that there's no mandatory psychiatric assessment. And even when the person is referred to a psychiatrist, that discipline itself concedes that while the expectation of the assessment of capacity will be definitive, in reality they are a process, complex in nature and inherently uncertain. What about voluntariness? This is really important, isn't it? Because yes, all the acts talk about this, and they talk about pressure or duress, which is a very high bar, of course, and that is universal across all those laws, and coercion being a statement of law or a term of law, action or practice of persuading someone. So we see that, of course. But we also see clinically a spectrum of pressures and potentially some sub-statutory influences on people that would not meet that high bar. So, of course, at one end, you've got a spectrum. At one end, you've got where there's no pressure or no influence on a person. And the other end, you've got coercion or undue influence. But are there things in between? Yes, there can be some degree of pressure or influence that may not meet that legislative bar and stop the whole process entirely, but truly are there, present. And what are those substatutory influences? Well, they may be covert, or they may be overt or covert. So an overt thing would be a direct encouragement from a relative, say, Mum, perhaps this would be for the best. Why don't you do this? Now, this would not be seen as coercion, and unless there was a particular aspect to how this was being addressed. But in a general sense, this would be a substatutory influence, if you like, on the person. What about covert? Well, there are lots of different things like the patient senses that their family think that they are too long. I look into their eyes. I look into the eyes of my children and I think that I'm living too long. I worry for them. Those sort of comments. Frustration expressed by loved ones. Maybe it's best because they're frustrated, my children, maybe better if I went. Others with this level of despondency or loss of control choose this. So if other people do this, maybe I should think about it. Oh, the VAD is legal. Well, if the society thinks it's okay, then it must be. Society's acceptance of VAD as a way of dealing with suffering means that according to assumption, VAD becomes just another end-of-life choice. So that story of the legality. Absence of adequate medical care, including palliative care. Now, you've seen the map. And you've seen the extraordinary size of this country and the paucity of palliative care throughout the country, but particularly in rural and remote areas. Well, if you're in a particular place and you've got very little or no access to palliative care, you may say, look, no doctor is able to control what I'm going through. Maybe because of this absence, I will opt for VAD. So just in terms of these substatutory influences, encouragement, but multiple other subtle or covert things that may occur. Each of these pressures may exist in the context of a vulnerable patient. So it's a combination of these pressures and the vulnerability. So we're now noticing this or thinking this through here, but this would be universal observations, of course. The vulnerability of feeling or fearing of being a burden, of acknowledgement of frailty, acknowledgement of dependency, low self-esteem. I'm not worthy. Why would my life can finish now. I'm not a worthy person. History of physical or emotional abuse. So lots of different things can occur. Informing the family, this is the next topic. The law is silent throughout Australia on whether the person needs to inform their family about the VAD process. What does VAD mean for palliative care in this country? So this is a question that's being asked more and more. Who are we? Who are we in palliative care? One response to that question is the definition of palliative care that is the foundation stone of our practice. And we go to the WHO definition that you're all familiar with, including that palliative care intends neither to hasten nor postpone death. VAD does not fit into this definition. And yet, patients with life-limiting illnesses with reduced prognosis are precisely the same patients that fall within the legal definition of eligibility of VAD. So while the patient group falls within the definition of palliative care, the action of VAD does not. In the ongoing debate on VAD in this country, several questions were and continue to be asked of palliative care. And these questions we're hearing many times. If this is precisely the same group of patients and your stated objective is to manage the suffering of patients, why can't VAD be part of palliative care? And the second question, subtly or very overtly, is, aren't you doing this anyway? Why can't VAD be part of palliative care? So, well, yes, the recognition and response to the suffering of patients is central to the practice of palliative care. But there are clear authoritative statements, and not only statements, but ethos differentiating palliative care from VAD. And we've talked about the WHO statement, Australian New Zealand Society of Palliative Medicine, which represents doctors, physicians working in palliative care in Australia and New Zealand, has a position statement. And also, very interesting, in South Australia, we have that remarkable commentary in the South Australian Act. So, and that this position statement does not include the practices of that. And then we've got the South Australian Act, and I'll put that up before. But aren't you doing this anyway? So look, we do a very orthodox response to this and say, well, actually, no, this is not standard of care or part of palliative care at all. And the proportionate use of medications such as opiates and benzodiazepines does not hasten death. And the use of those medicines to intentionally cease a person's life lies outside the standard of care of palliative medicine. The effect on health professionals, and I might make some of these will be part of the conclusion now. So effect on health professionals, this is interesting and perhaps an unknown, and there's necessarily an intangible aspect to this. But on 2 occasions, a VAD doctor that I was speaking to used the same words. And these 2 VAD doctors said the following: I don't sleep the night before I give the injection, and I don't sleep the night after. And they revealed to me they found it hard to put it into words, how they were feeling about this process. It certainly wasn't a statement of, I'm only too delighted to be doing these acts. These were doctors I could see who were struggling. Interesting. Now, there's just only 2 doctors, but this perhaps the only time I've got perhaps into the inner thoughts of those VAD doctors, the only 2 known VAD doctors I've met. Also, this is coming from, put this next slide up. This is coming from a professor of palliative medicine, Odette Spray, in Victoria, and her commentary in the Medical Journal of Australia. As a palliative care specialist, I have found the institution of Victorian law to have a devastating effect on my practice. I have witnessed the devastating impact on this law on the cohesion of teams, on the relationship within clinical units, and as a cause of deep moral distress among many of my colleagues for whom this law and its accompanying narrative is anathema to the very core of our sense of what it is to be a doctor. Now, that's a very strong statement from Odette, isn't it? Then we're starting to hear, and we've only had it implemented since late November, this interesting comment: VAD is becoming normalised. Now, Victoria has the longest, is the first of the states, so that has the longest duration. To me, it may or may not be being normalised, but it doesn't stop it being an abnormal process that you are deliberately, intentionally stopping the life of a person through the actions of a doctor or a nurse practitioner or indeed a nurse. So I think we just need to be a bit careful here that story doesn't sort of become the mantra, or this is all normalised, certainly for junior doctors, where they think, okay, well, this is just part of the routine, or versus a pause and a careful thinking through what actually does this mean. The clinical scenarios we've witnessed, well, this was an extraordinary case, an NMD ALS patient. He requests VAD. He completed his first assessment. He deteriorates. Then he's admitted to a faith-based hospital and hospice. So there's a big story as what's going to happen next. His second assessment's due. On that day, he was not well enough to be transferred out. So he couldn't go out. And immediately the VAD service said, okay, are you going to allow a VAD doctor to come in? And we said, well, no, you know that we're not allowing VAD doctors to come in. And we explained that we have a policy of non-participation. But then the next day or so, he was well enough to be transferred out. So we sort of swung from not feeling he's not well enough to be transferred out to being, and then this conversation started to unfold. It then becomes apparent that in order to complete the multiple steps in the VAD process, he would need to be transferred back and forth from the hospice to complete that whole process. When this became apparent, he said, forget it. I'm happy with the care I'm getting here. Stop the process. Now, that was a very remarkable day when that occurred. We were very conscious that, well, I was very conscious that this was, there was no deliberate manipulation of the process. It just happened to land where he said, well, if that's the case, then you're doing an okay job. I want to keep seeing you and the palliative care team here. Just let me be. Let me die here. Another interesting case, a 74-year-old metastatic man with metastatic colorectal cancer, recurrent episodes of bowel obstruction. He requested VAD. His wife was clearly ambivalent. His daughter was very enthusiastic about VAD. He was transferred to a faith-based hospice. The daughter, when she realised we had this policy, was savage in her criticism of the hospice for its policy of non-participation. And indeed, she's made an official complaint. Now, the response to that official complaint would be to say the law, the VAD law, allows us, this particular hospice or a faith-based institution, to declare non-participation and to all that flows from that. Then what happened was that he eventually went home. He was having community palliative care. There was issues, or the wife was saying, I think he's having misgivings. When the question was directed to him, he said, no, I'm not having misgivings. The daughter was there, of course. At a certain point, one of the palliative care nurses thought, is this man depressed? So he had issues then of capacity and also a fixed firm view on the VAD. So it was starting to get more complicated. We rang the local doctor who said, I've never heard about this. This is the first I'm hearing about this. So this turned into a whole story of the VAD doctors, the necessity of them communicating to family physicians of what's unfolding. The family physician was excellent and had a long conversation with him. And at the end of that conversation, came away convinced that the man had capacity and that it was a fixed, clear view, and the VAD went ahead. But, you know, this is just illustrates of how even on a daily or half-daily basis, things can start to switch and turn, and are we certain, and what's going on there. And also this...
Sorry, Frank, we're at 8:40 now, so
very good.
You might like to summarise.
Summarise, yes. Well, in fact, I've come to the conclusion there, which is there. So the landscape of end-of-life care has changed in Australia. What was illegal is now legal. Hopefully this has given you a sense of this. There's 6 separate jurisdictions, 6 separate laws, but bit by bit, it'll be a question, as it happens around the world, whether these laws are then amended or changed to advance the process of VAD or the eligibility of VAD further. But thanks, Sinead. Thank you so much.
Thank you, Frank, for a superb, and sorry for interrupting you there just as you were coming to the conclusion. Superb presentation covering, as you said, a huge continent. While John and Catherine may check on whether there are any questions through the Q&A, and encourage you, those of you online, to put your questions in the Q&A I will just ask you a few questions, Frank. I mean, two things that came out as extraordinary to me were Justice Abraham's 2023 rule. I'm afraid I don't have the legal terms, that suicide is part of the same story, that voluntary assisted dying and suicide are part of the same story. So if you wanted to comment further on that. And the other was the South Australian legislation saying that palliative care is not part of VAD. Any comment you want to make about how the South Australian state achieved, how that was put in, what led to that being put into the legislation, and also what you think has further implications of Justice Abraham's ruling?
Thank you, Sinead. Yes, so this ruling, I mean, there was a great deal of hope, I guess, from the VAD community that this would allow the possibility of VAD doctors using telephones or other carriage services to communicate. But he has very clearly stated, no. The suicide VAD is part of that same story, and as a result, the Commonwealth Criminal Code does apply, and it does mean that throughout Australia, doctors cannot use a carriage service there. So what's now unfolding is that there's been lobby to the 6 state attorneys general and the Commonwealth Attorney General to change the Commonwealth law. So that so VAD would be hived off, and VAD would be seen as a separate story and not part of suicide, not suicide. So I guess we just wait to see that. So there's lobbying back and forth, of course, in that context. But it is a source of frustration for VAD doctors when they've got a person who's not well enough, perhaps, to come to their clinic or to the hospital. Well, why can't I? Well, the law says you cannot do that. The next thing is the South Australian. Now, that's a very fascinating part of that act, isn't it? I've spoken to one of our colleagues, one of the leading palliative care physicians in that state, and he said that he and his colleagues advocated strongly for that to be inserted, and it was accepted to be inserted. So that's interesting, I guess, the power of advocacy in new laws or even a current law where potentially you, within the palliative care community or medicine generally, potentially could say, look, as one of the many things we're concerned about, this is a concern because it seems to be conflated in the public mind. Okay, we would like this separated and expressly separated. So it's a very interesting example, isn't it? And certainly in South Australia puts to bed any suggestion anyone would say, oh yes, but that's all together. You know, VAD should be part of palliative care, should be, well, no, the law says, no, they are completely separate.
I have one more question I can see, and then I'll hand over to Catherine and John. The New South Wales legislation where it says that the palliative care or the doctor cannot withdraw their service even though they are a conscientious objector, is that difficult or tricky, or in keeping with, is that consistent with good palliative care practice? I mean, you're in New South Wales, so
indeed, yeah. No, I'm entirely comfortable with that because there was no law that needed to say that to us, but it is in the law. It's just perhaps reminding everyone that they can't simply abandon patients, and one of our main principles is non-abandonment. So we say to everyone that we're here for the long haul to our patients. We're here as palliative care health professionals all the way through. We're not going to abandon you. We're not going to walk away from you. And I think that that's a very good, well, obviously a high ethos, a high philosophy of care, isn't it? And it does prevent anyone saying, okay, well, you need to leave this institution. You can't. We're not going to continue to care for you. No, that behaviour cannot occur. We will always do that. And also, what it does, Sinead, interestingly, and I'm starting to notice this, is that when people realise that they may have thought that, okay, if I go down the VAD line, I won't have palliative care. I don't need, palliative care will not care for me. When we say that, that I think that impresses people that we'll continue to care for them. And indeed, that example with the NMD, the ALS patient, where he says, well, you're caring for me. I like the care you're giving. So continue on. That's okay. I'm okay. I'm not going to be abandoned. Yeah.
Thanks very much, John. Frank. So I'll just hand over to John and Catherine, whether they have any additional questions of their own, plus from the audience.
So there's a linguistic question in the Q&A. Grady Crossland wants to know, what is a carriage service? I don't know what it is either. It must be an Australian term.
Yes, a carriage service would be telephone, internet, email, FaceTime. A carriage service that way. So basically an electronic way of communicating, essentially, and telephone.
Thank you. There are no other written questions. Maybe I could ask you, Frank. So I live in Montreal, Quebec, and Quebec passed a law not long ago obliging all hospices, which we call palliative care homes, to provide MAID regardless of their religious or other principles. And the reason given is the whole question of the difficulty of transferring patients. And so you mentioned one case where the transfer became problematic. One of them turned out in the patient saying, forget about do you see this as leading to open confrontation? How do you see this going in Australia?
This is a really interesting question, Catherine, because I sense that there may, if this story unfolds, over and over, then I can sense that there may be a frustration expressed by the VAD services or VAD doctors, or indeed the society, about this. I think that the law allows us, faith-based institutions to non-participate, but I'm just wondering as time goes on. And particularly in this context, where by that non-transfer, the patient deteriorates and dies potentially before the VAD occurs, and how that is seen. So I can, that is very interesting what you've said about Quebec, because that potentially, now I don't know, but potentially may be a source of exasperation, frustration, potentially, by the VAD community, that this is occurring. So that's an interesting question. And then if it were to be that we tipped into an amendment as Quebec has done, I'm not sure how that's going to go down I'd be interested to know how it's gone down in Quebec among those faith-based institutions, because certainly in Australia it's been, quite robust. This is the law and this is what we're doing.
So in Quebec, there are actually almost no faith-based institutions. Most of them were given to the government when public healthcare came in 50 years ago or so. There is one that is run by a non-religious nonprofit organization, but it's on land that was formerly a church and still belongs to the Diocese of Montreal. So, in fact, not the institution, but the Archbishop of the diocese has challenged this requirement in court and asked for an exemption, and that has just started in the last few weeks. So we'll see how that plays out. But there are a lot of questions about religious freedom, about freedom to determine what goes on in property that belongs to you, and many other things. So it sounds like the network of faith-based hospitals and hospices is stronger in Australia than it is, at least in this part of Canada, although in other parts of Canada there are major hospitals that are run by religious organizations with agreements with the public system. But anyway, I'm glad to hear what you said about Australia. I hope it stays that way.
Thank you, Catherine. Look, the one exception I should say is the residential aged care facilities. So if that's been run by a church, the law says residential aged care facilities are seen as a person's home. Yeah. So that the law says that you cannot declare non-participation because it's a person's home, that even in a faith-based residential aged care facility, you need to allow the VAD doctors to come on site. So that's the exception. But what I'm speaking about through that talk was more hospitals or hospices.
Yeah. Yeah.
Frank, I have a question for you. There are no other questions coming yet from any of our participants. My question is around the fact you mentioned 3 states, 3 of the 6 states allow health professionals, I guess that's doctors, although you also mentioned that nurses in some jurisdictions, some states can actually participate in this, but that some of them allow the doctor to initiate the discussion. And I'm just wondering if that's something I have concerns about. We lobbied very hard to make sure that that wasn't part of the New Zealand law. That could well change because there is some indication that some doctors aren't happy about that. So I just wondered whether, given that you've got 3 states where that can happen and 3 that can't, is there any research or any emerging awareness of differences? Does it give some credence to the idea that this is a good thing or a bad thing or it doesn't matter thing? Are you able to comment on that at all?
This is a really interesting question, John. I guess because we've had a sort of a staggered entry into the field, and New South Wales being only of late November, it's quite early in my state. As far as I know, there hasn't been any research done. As far as I know, I haven't seen any public fora discussing that. But if you were to get a public fora of palliative care, or really any doctors from multiple states in the one room, yes, that certainly would be a topic. I think in Victoria was the first that they were under heavy pressure to basically make it very as tight as they could, but as we know that it cannot be watertight, this, because of the nature of things. So that's why they had that. The first of the states said you cannot raise it, and then bit by bit people said, oh, hang on, that doesn't really work, and so it did occur. But it's a really interesting point you'd make in terms of perhaps the frequency of it being raised, the preparedness. Well, obviously under a law you cannot raise it, so you're waiting for the patient to raise it, versus another state where you could raise it, but in the same conversation talk about other options, including palliative care. But it's an interesting point how that might then play out in practice. As to how those doctors feel about that, and also the numbers of people saying yes or initiating or not initiating, or yes, it's interesting.
Thank you, Frank. I just have a question. We're coming towards the close of this webinar. You mentioned, Frank, and you gave an example of speaking to 2 doctors who are involved in voluntary assisted dying, about the effect on health professionals. And I know it's relatively new in New South Wales, but you may not have any. Is there any research being done in that area, or are you any other comments you want to make about the effect, perhaps on the palliative care health professionals?
Yeah, the palliative care, I mean, this, for obvious reasons, this has been an enormous story for palliative care in this country. The long lead-ups, because as the acts were passed, each act said you have 18 months to prepare for implementation, so there lots and lots of discussion. I think a lot of concern among really all palliative care physicians that I know, though I would say there are 1 or 2 exceptions that are VAD doctors essentially, and they've welcomed it. I also see some, if not consternation, some concern among my junior colleagues as palliative care trainees. What does this actually mean? What is our role? How do we respond? All those questions start to come into play, and not everyone's a lawyer. Not everyone knows or sits and reads the law. So it's a lot of discussion and chat that does occur. I think it can be difficult in a public hospital situation where a palliative care team en masse together, unanimously, conscientious objectors, but in a hospital where VAD is occurring, or an expectation on palliative care to assume that role. And I've certainly had that expression made to me, and I think my colleagues around the country, but you are end-of-life care specialists. Surely you're going to be doing this. Surely you're going to be taking charge of this. And when the answer comes back, well, no, there's like a puzzlement as to why you would not do this. So I think that careful explanation of our role is there. I would say grand rounds around this country have had grand round presentations on this topic as people start to wrestle with this. So I think the overt, covert, tangible, intangible effect on palliative medicine is quite strong. Yeah.
Catherine, are there further questions? Thank you, Frank.
Yes, there's a new question. Whether nurses and nurse practitioners are more or less inclined to provide VAD compared to doctors?
That's a very good question. I don't know the answer to that question. I don't know. Well, I mean, the society of each of these societies would have their own statements on this. But in terms of a plebiscite or a survey, if you like, of nurses or nurse practitioners, I don't know. Well, I mean, I perhaps have an indication there. About 6 months ago, I gave a talk to New South Wales nurse practitioners, palliative care nurse practitioners, and this was not a divided group, because they're a very, very good group, but there were varying different views expressed about this. One said, I'm going to become a VAD practitioner, and I'm going to train, and I'm going to do this. I'm going to work with the VAD doctors. And others who said, well, no, that's not what I would do at all. So I think that there's probably quite a spectrum, if you like, there.
There are no other questions written. If anybody has a question, I guess there's like 1 minute left. Is that right, Sinead?
That's correct. While we're waiting in case that question comes through, just to thank Frank, an extraordinary and fantastic presentation on the continent of Australia and the assisted dying legislation. I mean, it was a point you made, and just to clarify, Frank, you said the normalisation of the process. Were you cautioning us about the language used in that? Because, for example, in opposing the legislation before it came into effect, we would have said, oh, this is a risk of normalisation. So we use that term. But I think you were saying this is an abnormal process, and to be kind of cautious in the language we use around the word normal.
Yeah, well, I certainly wasn't going to prescribe language, but it just struck me when that was said. And relatively, 2 to 3 months after starting that was said, and I thought, and it was said by a VAD doctor, mind you, and I thought, okay, you're saying this, and it may be a lovely, it's a mantra, perhaps even to say here, a point of relaxing, if you like, into the process, but there is another thought on that. Yes. So it's perhaps more just how we see that expression being used by our VAD colleagues, the doctor colleagues, health professionals, the general society. Yes, okay, there are numbers of people having it, but we just need to be conscious, certainly for our junior colleagues, that's it. There's something about that word, that this is normal. Well, okay, if we unpack that there's something very abnormal about this.
Thank you, Frank.
Dr. Mark Comrade just wrote in the chat a reference to Robert J. Lifton's term, malignant normality.
Yes, that's right. Yes, that's an interesting expression in this domain, isn't it?
So we've now reached the hour. So it's my privilege to thank you, Frank, for, as usual, such clarity of thought. So we were really privileged to have you present this webinar. And we look forward to our next webinar. We hope to host another 2 with Willem Lemons and Theo Bohr over the next, in the coming year. So once again, thank you, and thank Frank, and thank the participants and Catherine and John.